Welcome back to our second part of transformation models. We began in our first talk of the week to discuss the principles or the preconditions for sustained change according to the seed scale model. And we're looking at this model again so that we can design strategies to more fully understand the transformation goal that we're shooting for in order to develop the skills that we need in order to make that transformation. So we've said we're using Melnick's evidence-based practice model as well as the seed scale model for sustained transformation. And those are our primary guides in the DNP project course to help us map the vision of transformation, where we hope to go with our projects and how we hope to transform concrete practice and policy in whatever arena we find ourselves in. So I gave a brief summary of these principles in our last discussion. I gave a case example of how missing a top-down partner in a tertiary health systems approach to change resulted in the ultimate failure of that change process to take off and be sustained. Now I'd like to flip the story and tell a positive story where these four principles were at play, and then describe how they contributed to the launch of our change process. So at a health facility in East Africa, it had developed in the early 2000s through one physician's initiative in partnership with a faith-based organization and a university. And they developed a clinic that focused on HIV care. And despite its modest beginnings in conjunction with what was the equivalent of a nursing home, this facility was able to gain reputation throughout East Africa. It was even recognized by the president as an exemplar of PEPFAR HIV care. But prior to that, we started an initiative to look at how to optimize the continuing education for health professionals that were not clinical by a standard definition, not physicians or nurses or medical officers, which are the rough equivalent of nurse practitioners. But those people who had clinical contact with patients oftentimes didn't have any continuation or skill development opportunities like the physicians, nurse practitioner equivalent and nurses did. So what we did is we came in and partnered with the clinical organization. We began with three-way partnership. We had all of the clinical departments meeting together to share their perspective. I was on the team as an outside-in technical expert in educational content delivery and adult education. And we also had top-down buy-in from the highest level of the facility, as well as the site manager who oversaw all the departments. So we brought all three partners together. We created a data gathering process to characterize the perceived needs of all of the staff member in those departments. And we had face-to-face discussions and key informant interviews to understand the practice needs they had. And we've identified what strengths were at place in those departments and between those departments, because they'd already become a referral center for East Africa so that patients were traveling from other countries to receive care specifically at the center. So they had a lot of robust skills to build on. And the practice change that we designed, I'll begin to talk about in our next step. But all of the work we did, again, was focused on the structures of care, the mechanisms of care delivery, and how the clinicians cared for patients. They were not focused on teaching knowledge or providing technical expertise per se, rather on changing practice. So we started with those four principles, and then we moved toward a systematic process for sustained change. So I'd like to walk you through each of these three steps. First is building capacity, creating vision, and then acting. So those are depicted in the various shades of blue in the center. So what we began to do is we wanted to build capacity by creating an innovation team. So we had a team of implementing experts from all of the departments at this clinic that provided services like social work, counseling and testing, home-based care workers, nutrition. We brought them all together to discuss the insights from the data gathering process so that we could all look at it together. We analyzed what the strengths were, the resources at the facility, and then we created an intervention package that was customized to those departments' self-identified needs. And we used multiple theories. We used seed scale theory, which we're talking about now. We used the best practices on adult education in terms of small exposure to information with many opportunities for customization and practice. And so we brought adult education, seed scale theory together in order to build the capacity for delivering the intervention. And it was made in partnership between an academic medical center that had 25 years of experience of consulting and partnering in health research in this particular country. And content experts in HIV were recruited from the academic medical center, as well as information technology experts on the ground in the host country and on the ground at the academic medical center. And a curriculum was designed that was based on the locally identified needs. So we brought together those partners, looked at the data to build capacity, brought together a diverse team of people in various functions and roles. And then we began to ask the question, what are the learning priorities and the goals of this intervention? And what was decided is that we would create a synchronous learning opportunity to take technical expertise from the medical center, but customize it to the level of clinical care and service delivery for these clinicians who were home-based care workers, adherence counselors and testers, nutritionists, social workers, so that the information being delivered was not esoteric HIV technical expertise, but it was very specifically designed to equip these clinicians to care for the patients that they were seeing in their center. So the priority was around skill development, and we focused on three primary areas. We focused on mission and vision within all of these departments that were housed under one umbrella to help them function more cohesively together. The second area focused on knowledge of HIV pathogenesis, so how the disease worked, pharmacotherapeutics, and how the drugs interacted with the disease. So that was more on the technical side, but again, it was customized to the department's self-identified learning needs and educational background. And then the third area was looking at system change. We looked at topics like motivational interviewing, how to deliver knowledge content to patients, but in a way that was actionable to the patient. So not just delivering information, but helping them to change their own practices so they could manage their disease themselves more effectively. And then also within that domain, we looked at how these departments could more cohesively work together by using a common mission and vision to orient the work within each department to move forward toward a common goal. So that was an educational method. It was delivered synchronously between the medical center and the clinic over the course of 10 weeks. And that was our action plan. We implemented this. We obtained feedback on the process from the learners who participated in the course and made some proposals for follow-up, action-oriented, practice-oriented education and redesigning the curriculum for future iterations. And as we engaged in this systematic process, we started with a team, looked at successes, brought the best evidence from adult education, seed scale method, HIV knowledge to bear on the local priorities that were identified in these departments, and then created the educational intervention. All of the assignments and activities were based off the lecture content, but then the participants took that knowledge and directly applied it to specific patients and specific situations in their practice experience. So that was the collective experience of beginning with the principles for change, then focusing on a systematic process of change, which was iterative, because once we delivered the educational method, then we gathered data on how to revise and improve it for future implementation. So as you can see, by beginning with the principles, engaging in a systematic process, we were able to take steps toward health transformation, where there was participation among those who were involved in the intervention. It wasn't an intervention done to these departments, it was done in collaboration with all three partners. And it was done in a way that invited their voice and allowed for sustainability, because it could be focused on practice and it was designed with their voice so that they could then be owners of that process and designers and re-implementers. So at the conclusion of that process, the expansion that we achieved was looking at local success and learning. So we expanded through scale 1, where we were reflecting on practice and improving practice in that context. So as you can see, we started looking at the principles and we engaged in a systematic process of change to transform the process and the system of healthcare delivery at this already strong HIV center in East Africa. So hopefully you've seen some of the concreteness around these principles, so you can begin to think about how they will relate to your own context. And this now can serve as a roadmap for us as we think about how to create transformative, innovative, and sustainable DNP projects and DNP project-based changes with our clinical partners. So I hope that you're beginning to see the power behind the seed scale model for sustained transformation, and that these principles begin to be a culture for how you think about change, so that when you begin to engage with your clinical partners, no longer will we come in as DNP doctoral student experts who are going to implement and do something, but we're coming in as collaborating partners whose ears are very big to hear about the local context and needs, and who can bring our expertise to the table in collaboration with the implementers in that partnership, as well as the administrative decision makers. So our next step, we'll look at the model of evidence-based practice from Melnick. Have a great week.